Good evening, everyone. Welcome to the Senior Registrar Forum conducted by Sri Lanka College of Internal Medicine. This is the second Senior Registrar Forum of the year and first forum under the new presidency. And the Senior Registrar Forum is the brainchild of our immediate past president, Dr. Gayan. We conduct this to upgrade the budding internist knowledge, not only them, even every one of us get the good knowledge after this program. Before starting the today topic, I would like to invite our president, Dr. Kumuduni Jayasinghe, to address you all. Dr. Kumuduni, over to you.
Thank you, Dr. Primali. The only thing that I cannot on my video. So can someone allow me to on this my video? Right, okay.
Yes.
So thank you, Dr. Primali, and good evening. I warmly welcome all of you, the consultants and our senior registrars and other doctors for this SLCIM SR forum. As Dr. Primali said that Dr. Gayan, our immediate past president, is the one who established this SR forum and to make you all more competent internists in the future. So we know that this SRs, the internal medicine has become more popular, not only in Sri Lanka, in other countries as well in the recent times. And this training of internal medicine is actually the other countries like United Kingdom and Australia. They have restructured internal medicine training program. And the PGI here too is currently working on restructuring this post-MD internal medicine training. So the PGIM has invited our college, Sri Lanka College of Internal Medicine, to conduct skill training workshops and also to prepare some learning modules. So we are happily actually accepted that invitation. So without further ado, actually, I would like to thank today's speaker, Dr. Gayan Ekanayake, the consultant plastic and reconstructive surgeon, for sharing his expertise today with us on management of pressure ulcers. Actually, a much wanted topic for me, actually. So thank you so much, Gayan, for doing this lecture for us, and also our moderator and the organizer, Dr. Primali, who has been doing this for the last year, has done a wonderful job. So, and she agreed to continue the same this year too. So thank you so much. And so I will invite all of you to get the maximum benefit from this workshop, the lecture today. So thank you so much.
Thank you, Dr. Kumuduni. Without much delay, may I introduce our speaker and the topic. Today's topic is what internists should do. I mean, just before the surgical intervention about the pressure ulcers. So we all day-to-day come across these patients, mainly because geriatric population is rising. It's a big problem to every one of us. So I think it's a very important topic. So our speaker today is a dear friend, Dr. Gayan Ekanayake, consultant plastic and reconstructive surgeon, National Hospital Sri Lanka. So without much ado, may I invite Gayan to deliver his talk. Over to you, Gayan.
Thank you, Primali, for those wonderful comments. And we will start the topic because I want this to be a sort of open forum. So if you have any questions, just post in the chat box so we can question and answer session, so we can be more proactive when we discuss things that are really troublesome for you. So when we talk about pressure sores or the bed sores or pressure ulcers, there are so many names for this, but basically the term or the concept of pressure ulcers, is it a surgical condition? Now that is a very important question. Of course, yes, when you talk about the ulcer itself, yes. But are we treating the condition or the patient? That is the main important question. As a plastic surgeon, the whole algorithm is now focused on the patient, not only the ulcer. So the patient more, there's a spectrum of patients that we get. You get patients with small pressure sores on the ischial tuberosity who are doing everything other than walking. So then you get the other variety where it's moribund patients who are getting in multiple pressure ulcers everywhere, all over the body, wherever there's a bony prominence, they get ulcers and they deteriorate fast. So it's a spectrum, and I will start with the worst case scenario of surgically sort of a patient who is bedbound, and probably common example is after a stroke or after maybe a tumor excision on the brain or some neurosurgical procedure. And the other condition is like quadriplegic patients in the acute phase. So now most of these patients biologically are these are indicate we feel that they are actually that's an invitation for their demise. Basically, historically, they have been this event would generally lead to death. Because simply because there was not much of an understanding how to care for these patients during their last few days or few months. Now, so when we talk about those patients, it is the surgery is actually something sometimes we should not be thinking of. I mean, some patients are not suitable surgical candidates, basically. So who should manage these cases, and what should we do with these patients? So this theory of the rehabilitation or the rehabilitation arm and the curative arm, the concepts are different, and the goals of treatments are different. Now, in rehabilitation arm, there are treatments, rehabilitative treatments also, but even the history and the investigations, treatments, everything looks towards a rehabilitation. It doesn't go into it's not a curative. We can't stop at curative procedures. So basically, the reconstructive history is different, where you might have to ask the patient or the caregivers about even the width of their door, how to take this patient from the bed to the bathing area, toilets, and how to transport this patient. How many stairs are there for them to carry this patient down and upward? So there are a lot more background details that are important in rehabilitation history when it comes to when we compare it with the curative history. So the curative history is basically we look at the patient, trying to make a diagnosis, and the diagnosis, and then treat the patient. So rehabilitation arm is I would say, I think, rests under physicians at current context. I think because there are very few, at least I know that there are no 100% rehabilitation consultants at the moment in this country, but I think they are in training. But majority of these patients will be in medical wards simply because they have lot of medical conditions. So they have hypertension, diabetes, and stroke-related issues, even aspirations. So a lot of medical issues with these patients. So this bedsore may not be the most critically important thing for these patients at that point. So having that concepts in your mind will move into the question whether it's going to be a rehabilitation or actually sometimes it can go into palliation also, or a cure. So these are some of the questions that we'll be asking a patient. When this patient came to me, the patient was bedbound and came with a urosepsis and had this enormous pressure ulcer on the buttocks. And there was a very loving daughter who looked after this patient, and he was not communicating well. He was having a hyponatremia, and there are several reasons behind this patient becoming bedbound. Actually, he was not. He did not have a stroke or anything. It's just he suddenly became weak and then got confined to the bed. Now, when I see this one, I know it's a surgical condition, of course, but in a medical patient. So there is enormous pressure on me not to operate straight away. However, there's a fine balance, because these are not things that you can keep on these patients for a long time, simply because the next hit is an infection, which might be the source of sepsis, and next septic episode may lead him to death. But the other on other aspect, if I create a big wound in this area, how am I going to manage that wound in this unstable patient? Or do I have any way of preventing this getting secondarily infected with other bacteria, including fecal flora and other multi-drug resistant bacteria if the patient is already on antibiotics? So this is another big problem. Now, shall we look at the sort of pathophysiology? I'm sure that this Landis chart, you will appreciate that ulceration risk just becomes enormously, it's just a very sharp curve. After about a couple of hours, you get this. If you see this chart, when you have 1 hour and compare it with 8 hours, it's about nearly the pressure, and we compare with the amount of pressure applied, you will see that amount of pressure applied is proportional to the ulcer risk. And you see the critical pressures are between the 12 and 32. So we call this an iceberg phenomena, because now usually we used to think, I mean, if there's something happening on the skin, the actual problem is much bigger inside. The sacrum and the muscles, sacrum, ligaments, and all those things are now probably past the mark of still being viable. Now, there are 4 hypothesized pathophysiological explanation of this development. Usually, it's what happens at cellular level or tissue level is a ischemia. There's one theory of ischemia caused by capillary occlusion. The occlusion, how it gets occluded, we will talk about later. And there's reperfusion injury, because it's a known phenomenon, but the amount of this injury is proportional to the muscles in most circumstances, because ischemic region has, if it has less muscles, less repercussion injuries. And impaired lymphatic functions, of course, the patients sometimes they are in the areas that are very closer to the ground level, or if sometimes we call it the amount of lymphatics that can be transferred, lymph that gets transferred may get stagnated in almost all over the lower body part rather than upper areas. So the lymphatic failure is a very critical factor. And also the mechanical deformation or the distortion of tissues can become another factor where the structure of skin may be damaged beyond repair in some certain extents. I will go into detail later on. So what exactly happens is that there is a removal of stratum corneum and there's hyperemia of the dermal capillaries and venules. This is mainly due to some stasis, because there is loss of the sympathetic tone in these areas, and there's dermal stasis and separation of this superficial layer of the epidermis from the deeper structures. So this is quite remarkable when you see the distortion forces that with different layers of the skin can withstand pressure, the tangential pressures, different capacity. So dermis is very poor in adapting, but the epidermis is a bit stronger. But when you have recurring these deformation forces, sometimes the epidermis gives away and the dermis will get separated off. And now what happens in the small vessels is that the fibrin thrombi and the red cells thrombi, and they can get they can clog actually these vessels, and they can cause ulceration of the epidermis or the basal layer. It gets damaged, and then the everything opens, the dermis opens up and causes destruction. Now the increase of depth happens not only due to lymphatic issues, ischemia, edema, and immune function issues, but usually the infection is one of the critical factors that can lead to more and more tissues getting ischemic and also invaded by bacteria. Now there is another recent evidence that says that matrix metal proteases, because the inflammatory responses are very diluted and doesn't really help to overcome this infection by the local mechanisms. And usually what happens is the infection becomes very rampant, and all these structures become engulfed by the bacterial growth. And now moving on to these types of patients. Now these patients, especially when they have spinal cord injury patients, there is another problem which is called denervation that's causing sympathetic tone, loss of sympathetic tone, and again this intensifies the problem. Now, this is kind of a rough diagram, but this is actually what you see. Although we say the pressure is high, the different areas of this pressure distribution, you can see these are the most vulnerable areas. First diagram is a patient who is prone, and second patient is actually someone who is who is actually in the supine position. And you see the occipital area, the thoracic area, and even the heel can get pressure ulcers. And it can go very high also. Now, when you get these cases, I'm just going through some of the theory on this. But the classification, there is a classification. So what are the cases that does not need any surgical treatment? So stage 1 and 2 are usually we do not go in jump. We do not jump and cut those patients. So these are actually medically managed in the sense that you can actually because usually these patients are in acute stage where they have acute medical condition and they are bedbound. And while on treatment, one aspect of looking at these pressure source is that that you need to look at skin of these pressure areas, especially maybe having a tick box daily and having someone to look at this, having interns to ask to in the daily rounds to have a look and see threatened areas. If you can pick these grade 1s and 2s, what the progression can be halted. I'm sorry, this small glitch here. Okay, I think I got it. I'm sorry about the delay. So now the stage 1 and 2 are basically medically managed. So if things don't progress, they can revert back to normalcy. So this is very important knowledge that I'm sure I'm not adding more and more pressure onto internal medicine teams, but actually it's very crucial that the ward doctors look at these areas and to see potential bedsore candidates, and if we can get them to break. Now we talk about other population. Now this may not be totally relevant to our populations, but these patients have other issues like nutrition, and they have pain issues because they may be having other problems like smoking, addictions, and sometimes suicidal ideas and alcohol, drug use, because we know that they are socially isolated. Sometimes they are socially isolated, and their needs are not fulfilled as human beings. So the depression and other issues are very rampant in these populations. And this happens when we talk about compared with the acute phase. This you can see the small diagram on the bottom right hand, and it is actually the ischial region where these are patients who have actually come out of the acute phase and they have become sort of independent, but they are on wheelchairs and can sit independently. They develop bed sores. So this is the other spectrum where the patients are quite independent and rehabilitated, but they still develop bed sores and they do not heal. So one word about ischial pressure sores. The non-healing of pressure sores is also another issue. So non-healing pressure sores are due to we are working on the theory of why this happens, and we have done some interesting discoveries in our unit. So this is not being studied properly, why these are not healing. So one thing is that wound contraction doesn't happen in a normal fashion. But most important reason is that they get epithelial, they get lined with the synovial tissue, and it doesn't allow the edges, the healing to happen inside the ulcer. So that's why you get a small opening, but there's a cavity inside. We're lined with the synovial tissue, and you get a lot of discharge. So this is a ischial tuberosity, and ischial bursa is actually connected to the ulcer. So this is the theory that we are working on, and the article is almost finished. So you might be able to read this article when it comes out of the into publication. And we have done some interesting histological discoveries in this study also. And now successful, we know it's a multifactorial thing, and for a internist, I'm sure that you might have this. Now now we are moving on from grade 1 to grade 3. Now we'll move on. We will talk about treatment of those things separately, but the goals, key goals in this treatment is adequate nutrition, because the nutrition is a crucial factor to fight the infection and also healing and so on. And resolution of infection, where these are usually not when the wound becomes stable, the infection is sealed off from the body by a fibrotic sort of a bed. So that happens in every chronic wound, where you get, the body has the ability to seal it off. But what we see is an ulcer. It's non-healing, but actually the body has already put a barrier, and it's not bothered about it, and it doesn't heal also, because it's counterproductive in healing aspect, because there's a fibrotic rim of protecting the other body tissue. But actually the infection is no longer a problem. It just is basically colonized, and it cannot, it doesn't require IV antibiotics or prolonged antibiotics, but it needs a lot more nursing care and the decolonization procedures, which can be done through the infection control strategies. So there are a lot of antiseptics available to these patients. So overuse of antibiotics, so the antibiotic containing solution, is detrimental to these patients, simply because you cannot prevent a colonization by just pouring antibiotic or spraying antibiotics every day. It doesn't work that way. So these are just colonized areas where you have a synovial tissue. There's fluid that is secreted, and there's bacteria that is lodged in these crevices. So it's cleaning, even with saline cleaning, and at least putting a dressing to absorb this thing would be the answer till a surgical treatment is done. However, decolonization is important just before surgery, because if you just decolonize and wait a long time, it gets colonized again. Now this other category, where they have spasms, a lot of spasms and contractures. The spasms, of course, can be due to endogenous, where the neurological reason behind patient being bed bound may be also contributing to spasm, because sometimes the patients are head injury patients, brain damaged patients. They can have spasm that can lead to lots of contractures, as well as very, very difficult nursing positions. So and they are painful to release also, and painful to rehabilitate also. So the idea here is you might sometimes use the Botox to neutralize these spastic muscles in early phases, but if it gets replaced with fibrotic scars, of course, there's no other way other than physiotherapy and splinting to correct these contractures. So these can be, it is a multidisciplinary approach for these things, and these things have to be done in order to do surgery, because you cannot position these patients, and after surgery you can't keep the patients on a suitable position, and if the patient goes back to lie on the flap might also dehisce, and the wound will be twice or 3 times larger than the initial wound. And I talked about a goal in certain patients. Certain patients we will not operate simply because we want the wound to stabilize. This ulcer stabilization theory is one of the most important thing. However, the amount of contracture, or the amount of wound contraction is varying between different patients and different areas of the body. Especially wound contractions over the sacrum is very, very good, and it sometimes contracts. I will show some clinical photos how it contracts almost 0 to a level, but it has to be a very good nursing endeavor to get that much of a contracture in wound contracture. This is not bone contracture, joint wound contracture in certain patients. Now, I'm not going to talk more on nutrition, but the nutrition target is about around 3 grams a kilo. It's an amazingly big load of protein that we need to put into these patients. So it may be through NG feeds, or sometimes a good meal for these patients. So vitamins and zincs and supplements are really necessary in these kind of patients. So now I'm not going to deal too much about these cases, but simple measures, how can we advise the juniors to look after these patients. So basically the patients, how the patients, the idea is to not to keep them in a position for more than 2 hours. So it's a common knowledge that you need to turn the patient, but the turning itself can cause pressure ulcers. That we know that stage 1, there are 2 categories of ulcers, where you get actual pressure ulcers, or the other one that we talk about, deformation ulceration, where it's actually a friction ulcer than real pressure ulcers. So friction ulcers happen when the skin is very fragile, and when we try to turn vigorously, and that areas will get peeled off quite quickly, and this category have to be very, very we have to actually take great care when turning. So these things need to be taught to the juniors, that turning should be a very smooth procedure, and turning should be done not haphazardly, but it's an organized way of turning the patient. And also lubricating these areas with if there is an ulcer, and keep the moisture, protect the moisture using a moisturizer, because that is very important, because the cracked skin is asking for trouble, and dry skin also is asking for trouble. So you need to use not a lot, just a gentle amount of moisturizer in these areas, pressure areas, as well as keep them ventilated, so there's not going to have the wound beds getting ischemic, and also bed for anaerobes to grow. Now this is what I've been talking. So the relieving pressure for 5 minutes every 2 hours, so adequate perfusion and prevent breakdown of protein. So it's a very important thing that this minimum of 5 minutes is important. You can place the patient back on the same same position. You don't need to turn and keep for another 2 hours on another position, but you keep it for 5 to 10 minutes and you can just put the patient back to the same old position, but then it has to be done every 2 hours. So this is one of the key elements that we can think of. And there are now there are the air mattresses that does this, and it relieves every couple of hours. It relieves pressures on areas and this changes the pressure areas. Now these are called low air mattresses, or where various gel and cushion, wheelchair pads, static flotations, and these are foam-based adjuncts, and these can be managed. And involuntary muscle spasms, so you need to control that, and also put them in a suitable position, get their resting position into a suitable level before planning the surgery. Definitely, when you talk about this colonizations, the idea is that the fecal flora cannot be coming into contact with the pressure ulcers. So generally, we will ask a GI general surgeon or a GI surgeon to do a defunctioning colostomy, which is actually a very logical thing to do, because these patients, when they become independent also, it's easy to change a bag rather than washing the back every time they open bowel. So it's a very however, the social dilemma, social issues are there. The patients feel that they are less than human if you have a bag on the tummy. So, but most of the patients, when you tell them that, having soiling every 2 hours and cleaning with lots and lots of effort, and also in this era where the Pampers are also very expensive, and when they talk about when you talk sense to them, they will listen, and they will probably agree fairly early for a colostomy till we finish our surgical treatment for ulcers. Now I'm just going to go through this patient, that's index patient. Now acute wounds are not suitable for flaps, so this patient might return to you with a thundering ulcer like this into the ward and a colostomy to manage the medical condition back again, because the amount of medical issues that these patients are having are not amenable for some of the surgical units, especially units like ours, where I have only my medical officers are near retirement, most half of them. So I don't expect them to do like an intern run around and these things. So it's very look at these medical issues of these patients. They have suddenly you get a chest pain and you have to do all these ECGs and send blood for these things. They get heart failure. It's not practical anymore. These smaller units with only medical officers, no trainees looking after these patients. Some of these patients, especially surgical trainees who are actually going to focusing on another area rather than medical problems. So this patient actually had this done, and now the newer treatment methods that we are now employing is vacuum therapy. So negative pressure therapy, where we use lots and lots of negative pressure foam dressings and machines to these patients. So they are more comfortable for the patient, as well as it cleans. Can you see the wound bed becoming has become matured and also the stable. Now there's you feel more comfortable looking at a wound like this, and it changes and it changes and it changes. So it goes, it reduces the size dramatically over a few. It takes months sometimes, but surgery is not the only thing that they need. And you can see the top right hand photo seeing that it's almost a negligible wound in that patient. This is the same patient. And the last one is that he got another urosepsis, and he was on this area for a long time, and he in the ICU, and he developed the ulcer again. So this is ulcer on ulcer. So it's a bad combination. Now, things like this are quite horrendous, and it's almost I would say these are nearly palliative patients. These are worse than cancers to have. It's just, you are going to end up having a huge ulcer, which is enormously difficult to manage in a ward. And we are looking at a enormous undertaking when we see this type of wounds. So idea is not to see these things coming out of when they come out of the acute illness. We should not see these things in these patients. And this is one of the huge debridement. Somebody has done it, and the amount of energy for nursing and everything is enormous, and the costs are also escalating enormously. And when you see these wounds, you know that it requires more and more surgical visits to theater. When this is one instance when you have a stable wound and the patient becomes bad again, and there is a little bit more necrosis happening. So this patient needs to go back to surgical debridement. Simply because what happens is there is going to pus is going to collect in between these areas, and the patient is going to become a nightmare for you to manage also, because this patient is going to use up all your NORAD and everything that inotropes that you have in your system, and in already depleted units, because the sepsis is going to become a real problem in these patients. Now, these are other categories where stable wounds are coming, and these patients can be rehabilitated quite well. Even with these big wounds, these patients can sit and do their day-to-day work. Now, this is again a stable wound. These patients can look after themselves, and they can actually go home, and they do not need a acute surgical intervention. They can actually be discharged. When you see this kind of a wound, they can be referred to a clinic, outpatient clinic, rather than keeping them in wards. So the flaps are something like this. These are flaps that are moved for these patients. And this is a tiny ischial bed sore that is being managed by a big flap. So just to round up the whole total management. Now, I'm sure that you have questions on this, and as well as the pressure sores are real problems, especially when you have elderly parents. You're a doctor and you are having elderly parents. You have to look after them, and it's quite difficult. It's enormously difficult to make decisions in these situations. And if there is a situation that can give rise to pressure sores, especially when someone is bedbound or having a stroke, or staying on bed because of a sepsis or something like that, and you need to be very proactive in protecting pressure areas, and also when you get a pressure ulcer, superficial ones, of course, moisture and maybe a superficial barrier cream that we can use is the cheapest that we recommend is silver sulfur-diazine. You might be wondering why silver sulfur-diazine. It's an amazing product. It has silver. Silver does not have resistance in the world. Although there have been a couple of reports of silver resistance in bacteria. silver sulfur is a quite a useful barrier cream to prevent infection. And other things are usually antibiotic containing ointments, fusidic acid, and also where you have we can actually use them, but they are not the main important thing. And gel-based dressings, when you have a big cavity, gel-based dressings actually promotes healing, and they can actually be used to improve the wound situation. I'm just going to read a few questions that have come. Questions have come. Somebody's asking how effective are mattresses in preventing and treatment of pressure ulcers. Of course, the problem is they are very effective when you put it on a patient who are already having a bed sore. It's not going to cure the problem. So the air mattresses is we found that they are very valuable because they are good investments for medical, especially medical units. If you have air mattresses for these bed-bound patients, I'm sure your life will be much more easier, because you will not see the amount that we are seeing at the moment. So you will cut down on bed sore development on these patients. And education of relatives and education of staff is very important to getting these ulcers detected early and prevented. Any other questions that we can?
Can I ask a question?
Yes, yes.
Yeah. Now, what we need is like this grade 2 ulcers, superficial, mainly the superficial type of ulcers. Are there any sprays kind of thing which we can recommend, rather referring to the surgeon like early? Yeah, I know this is a closed group. You can even talk about the trade name. That is fine, because there's a closed group among ourselves.
Yeah, I mean, there are different products available. Basically, I would recommend if it is grade 1, sort of a moisturizer. First line is a moisturizer, and there are good foam dressings which are called melalin. I'll type in, and they are quite useful, and there is only foam dressing available, I think, at the moment in the country. So there's no problem mentioning that name. They are much better than gauze dressings, because these are non-adherent, and they provide a cushion, and they also breathable. So the grade 1, even that is even good for the friction type of pressure ulcers, also the real pressure ulcers, grade 1s. And grade 2, as you said, the idea of grade 2 is to prevent infection. So it's not moisture, it's actually you have to have a barrier cream. So start with something simple and inexpensive for patients, like silver sulfadiazine, we call it flamazine, and those things, and they are quite effective. And soframycin, it's also cheap, and I cannot say I have used Tetracoat. I know that there are people who are using Tetracoat because it's a locally produced tetracycline containing ointment, and that is quite good. And there are various commercial preparations available. That there was one called I can't tell you the name because I'll be promoting that, because it contains lots and lots of antibiotics, which I don't think it should be used. But there are silver containing sprays which are doubtful whether it's really valuable in silver containing sprays, whether it's valuable. Of course, the other option is you can use sprays like there's gel sprays where you have aquacin gel spray, where you can have a spray the area with aquacin has buffered sodium hypochlorite, so you can spray the area, and then you can actually the area gets the bacteria gets destroyed, and you can actually spray the gel also and put a nice foam dressing on these areas. These are basically affordable ones. There are much expensive ones available. There are, I think, we have moved out from the multi antibiotic containing sprays because of the because it just sprays on the wound rather than combating what is happening inside. So a barrier protection barrier is it has this powder barrier, which is silica barrier. That is more effective than actually that is the effective part of these sprays rather than the antibiotics. So at the moment the market doesn't have any of those sprays at the moment, but I think I'm not sure I can help you out with any brands at the moment, because there's hardly anything other than the silver containing sprays available in limited number of pharmacies. I don't have experience because I don't use them. So, but it's available. It has come fairly recently, and the vascular surgeons are using for wounds, and they are using a trial. So once the trial says okay, we should be able to give a sort of a recommendation. You can use it or not, depends on the results, of course. And this is the situation. It comes to newer sprays. Is actually looking after the patient that heals the wound rather than some antibiotic spray. Yeah, but the idea is to have a barrier barrier cream or barrier ointment that prevents colonization of the wound ulcer. I hope I answered your question.
Thank you. Yeah.
So these are the wound measures that you can take, and you might use tule dressings. We had fusidine tule, sopra tule, and also bactigras, and just simple tules, because the wound adherence is of gauze is another problem. You can use it. And there are newer products like Airpo brand. There's a brand called Airpo. It has come very recently. It has silicone dressings, which are cheap, around 800 rupees. So it's quite cheap. You can apply it and on the wound. So it does not stick on the wound. It's a silicone dressing, and you can actually put a gauze on top of it. So it can suck all the fluid into the gauze. And as a Japanese product has come fairly recently, we are getting good results with it. It's for small ulcers. You can use it. It's called Plus Moist. Plus Moist. I will type in. You probably you should be able to get those. I'll write in the chat box for everybody. I'm a good because it's not it's a branded product, so it's a newer Japanese discovery. It's called Plus Moist. So this can be applied on wounds, and it just cleans the wounds very fast. And there are cavity dressings called cavity dressings, alginate cavity dressings. Alginate based cavity dressings. Dressings which can be used. The other type we recommend is called collagen particles. Collagen particles. You have several brands. If you say collagen particles, nanocol, and I think collagen, name collagen is all, the biofill. So those are some of the available products that you can promote healing in these wounds, and you don't need to refer them. You can just manage them. Basically, if you think that the patient is not a good surgical candidate, just manage them, because collagen particles are for at a later stage, not at acute stage. But the gel dressings are for acute wounds, and then alginates and collagens later, so it can actually promote more and more healing and wound contracture. So these are few of the products that you can use. Of course, they are not that cheap, but they are within a reach. I mean, they are less than the cost of a bystander. If I give you sort of cost, relative cost.
So anyone can type their questions so they can ask. We have unmuted all of you. Any more questions?
Gayan, can I ask one question?
Yes.
Thank you so much for this excellent talk. And once you put all this, apply this, what you said, the plasmoids and the alginate cavity dressings, how long you have to keep these dressings?
Usually 4 to 5 days. These are long duration. You can because the wounds are stable, and you are just promoting healing. You don't need to open them every day and try to do anything. Now it's quite easy to apply. But you need to seal the wound. So that is a very technically demanding thing, to seal these wounds. Sometimes we feel that the vacuum negative pressure dressings, the companies are now doing home-based negative pressure dressings also. They're quite expensive. We are waiting for Sri Lankan to develop this. It's a very easy process. Actually, we are not connected with lot of people. That's why we have this problem of not having developments happening in this country. But the negative pressure dressings are quite easy to work with.
One more question that you said about the negative pressure, the vacuums you said, no? So are these the vacuums are available in our settings? So
can you repeat that question, Kumudini, again?
Once you said the negative pressure, the vacuums, need to. It's very useful things. Are those available in our settings? So do we have to buy?
It's available island-wide, but there are a few companies who are dealing with it. And most likely, if you have a plastic surgeon in the region, and if you get you can get the regional sort of a guy who is the teams that are dealing with these negative pressure dressings, and they will be available at your doorstep. And if the wound is stable, the company nurse will come and put it, and sometimes we keep it for 10 days. So for 10 days, you don't need to put any dressing. However, if the seal is not good, then it's difficult. So someone needs to assess whether it can be sealed. The wound can be sealed. So the sealing, that means the wound has to be isolated. Sometimes it's very close to the anus. It's quite difficult. And that's in those instances, of course, you might need to close that small area. We might need to get a surgeon to close the lower part and do a colostomy, and then put the vacuum dressing, and then probably get a favorable result from using the money, because it's very expensive. You don't want it to fail. It's very expensive in the sense it goes in the range of 40 to 70,000 now. Bigger ones 70,000, but small ones get even 25,000. You get cheaper ones also. So yeah, that is the current situation about negative pressure therapy. So we can actually run a small, small sort of a online program to show what is the negative pressure. These are new technologies that are available for people who are willing to take up rehabilitation as a sort of, if you don't have a rehabilitation specialist, some of the patients might be benefited by physicians who's looking after this aspect. They can actually people can supervise these things, because there's a basically small one. The surgeons need not to be bothered about these smaller pressure ulcers. It can be dealt by the company, and as well as occasional referrals to. Once the patient is not going to have a surgery, so obviously the patient is a medical patient, and this is a junk that helps the patient get the proper medical treatment.
Thank you.
So it's thank you very much, Gayan, for that informative lecture. I think every one of us benefited with that, and that will be helpful for treating and looking after our patients. So thank you very much for your valuable time. And I would like to take this opportunity to thank Getz Pharma, who is sponsoring this for last year and this year as well.